it's almost very highly likely that it percolates to you. You are born to a bad genes. It's not your mistake. So gender is gender and genetics,
Genes,
both are very important. Eat slowly. Chew your food. I would recommend at least 14 to 16 times you chew your food before it goes into your stomach. That will sort of signal the brain that food is coming into the stomach.
Today we have with us on the Ivory podcast, Dr. Anand Rao. Dr. Rao is an interventional cardiologist with more than 2 decades of experience. He began his journey at the Medicity Hospital in Hyderabad, earned his cardiology degree from Nanavati Hospital in Bombay, and then specialized in complex coronary procedures at the Southampton General Hospital in the UK. Dr. Rao is renowned for his expertise in cardiac interventions and in providing cutting-edge care for his patients. Dr. Rao, welcome to the Ivory podcast.
Good evening. Thank you, Isaac, so much over here for having me. And it's a pleasure to be here.
So, Dr. Rao, the other day we were talking and you told me that you're a second-generation physician. We'd love to begin by understanding about your journey into medicine. You are a second-generation physician after all, so was it a lot of watching your own parent at work that got you interested into the field of medicine?
So what happened is I was born in a family where my father was a doctor, was a physician, a very popular physician. We hail from a place called Gulbarga, that's now called as Kalburgi, is in North Karnataka. So as being born to a very busy doctor, all we heard in our life was patients, medicine names, and my father running around for emergencies in the night. It is like somebody being born in a musical family. So you don't need a training. You automatically get trained into it. So he was a very popular physician, cardiologist in that part of Karnataka. And his social circuit was very, very big. And his group was very huge. He became so popular and research was just amazing. He was into teaching faculty for 20-25 years. More than that, became head of the department of medicine over there. Then finally he attained the very highest position what a doctor can achieve in our country is President of Association of Physicians of India. So he became that. So as being his son, I was very impressed by his dedication, his hard work. So that's how it began. And then once that started, I realized, MBBS is the way to go. And back in those times, we didn't have much options too. Either it was medicine or engineering. So medicine was the choice. So I joined medicine in late 80s. In 88, I joined medicine. And then, so I became the second generation from my family. In fact, my sister, who is elder to me, is also a doctor.
Okay.
So she is in United States. So I'm the third one, and my younger brother and another sister, they are not doctors. So being impressed by him, and he was like inspiration and huge popularity. Well, right now also today after gaining so much, I still can't fit into his shoes. But we've been taught we came up with a very strong foundation and good ethics and good practices.
Yeah.
So that's how I got into medicine.
Got it. And now here you are after 2 decades. You work with some of the most prestigious hospitals in Bombay and I'm sure outside as well. Yeah. After 2 decades of being in this field, what's the most rewarding part of your profession?
So I'll tell you briefly what happened is after when I was in the med school and we came to Bombay to get my uncle's angioplasty done. This was in 1991. So that time cardiology was not advanced and we didn't have stents at all at that time. It was just what is called as POBA, plain balloon angioplasty.
Okay.
So we used to just open with the balloon and make a pathway for the blood. If the artery holds well, good. Otherwise the patient is to end up for surgery. So interventional cardiology was not so advanced. So I came here and I went to Bridge Candy with my dad to witness that angioplasty in Bridge Candy. And once I saw that, I was so impressed. As a med school second year student, I was so impressed by this technology. I said, you are doing something outside and seeing on the screen and correcting this particular thing. I think it was amazing. You're not opening the chest, you're not doing anything. You're just doing it from outside, and you're seeing on an X-ray, film and doing all these things. So, as young as a med student, I realized, cardiology is my way of going it. Father was already an MD medicine, and at that time when my father was a student, the DM was not there, the super specialty was not there. But in our era, it had started, yes, and it was a big way. If you wanted to be in a city, in a big practice, you have to be a super specialist. So that's when I got into cardiology. I finished my MD, of course, medicine from same town. Then I migrated to Bombay, and I said, this is the place I have to be. And then I moved into Nanavati Hospital, where a very famous cardiologist was there, Dr. M.J. Gandhi. He's no more now. He was my teacher, my mentor, my guru, everything in cardiology. And under his tutelage, I trained for 3 years in cardiology. Then I went to Southampton General Hospital in UK, where I trained for complex coronary interventions. And in 2002, I was settled here, practicing, and So I said, it's been more than 20 years of practice now, but cardiology is advanced so much now, so much, and you have to be with time. Or you are left behind. Various any field, IT or whatever field, you have to be abreast with the latest technology and knowledge. I've been doing that, but I'm very actively involved in training the fellows and teaching the nuances of the intervention cardiology, because 80% of my practice is complex coronary intervention. 2002, that's when I started as associate consultant at Holy Family Hospital. Subsequently got attached to various other hospitals also. So the journey has been fantastic, learned a lot of things. And now, apart from coronary intervention, there's something called a structural heart intervention, where we do aortic valve implantation without cutting the chest. That's called a TAVI. So I am now with a very well-oiled machine at Leelavati Hospital. We are a group of 5 people, and we do TAVIs over there and various other structural heart intervention also. So from coronary to structural. So it's been a great journey. And 80% of my work is complex coronary intervention. So for my kind of work, I need a setup which has got full inventory, all the gadgets, intravascular imaging, rotablators, everything, and a lot of balloons and stents, high-end work. This is a very, very high-end work. So I do that, and what I'm learning right now is teaching the fellows how to perform this. So a lot of time I spend in my hospital where DNB students are there. I teach them a lot. Plus, I am a proctor. I'm a proctor. Proctor means a specialist in a particular field. So I'm a proctor for doing rotablation. Rotablation is a high drill crystal which goes inside the artery and it clears the calcium.
Okay.
So the technology is very old, but somehow the youngsters have not picked it up. And I've been doing rotablators right from 2006 onwards. So I go to various places to teach rotablator, and I've got more than 20 centers right now, and taught them hands-on experience how to do the rotablator. And so it's fun. It's now I think it's time. I don't say I'm not that old, but I think it's time to give something back to the community.
So a mix of active practice plus, giving back to the community through education.
Absolutely, absolutely. We have a very good teaching program. We have fellows. I have fellows. I'm a DNB teacher in Holy Family Hospital. I get 2 students every year, post-MD. And so once you are dealing with students, you have to read. You have to be, because they can ask anything from anywhere. So you have to be perfect in all those things. So it's nice. I mean, journey is very good.
Nice to hear that. Yeah, we spoke about your profession from a clinical technique point of view and the latest advancements point of view. I want to ask you now from a user or let's say a patient point of view or a lame person who is watching this, what is the difference between something called as a cardiac arrest, a myocardial infarction, and a heart attack? Do they all mean the same things, or clinically are they different events altogether?
Well, I'll make it simple for you. So cardiac arrest is a sudden sort of ceasing of the activity of the heart, It can be because of very, very low heart rate or no activity of the heart, or it can be secondary to a very high heart rate like 200, 300, 350 and above. It's fibrillation, what is called as ventricular fibrillation, where the body is not able to cope up, and then if you don't provide the right facility at the right point, we may lose him. So cardiac arrest is that. So anybody can have a cardiac arrest. Cardiac arrest may be from heart or maybe from other causes.
Okay.
So it can be anything. Whereas myocardial infarction is a medical terminology, indicates heart attack. So what you call as heart attack is myocardial infarction in our language.
Okay.
So heart attack is nothing but one of the arteries of the heart is blocked, is choked up, he gets chest pain, and that area of the heart which this artery is subtending to, that gets sort of infarcted. Infarcted means there's no blood supply.
Got it.
And then that particular heart becomes standstill, and that without blood supply, that can get into a ventricular fibrillation, and he can have a cardiac arrest.
Got it.
So heart attack is also one of the causes of cardiac arrest. A cardiac arrest can be many causes. For example, somebody with a rhythm abnormality in the heart can have a cardiac arrest. Somebody with electrolyte imbalance because of dehydration, all that can have a cardiac arrest. So cardiac arrest is a very broad terminology, whereas myocardial infarction and heart attack are occlusion of the artery of the heart, which is supplying the blood supply. So basically there are three arteries.
Yeah.
So one of them gets into trouble.
Yeah.
You get myocardial infarction.
This is a very much needed explanation because a lot of people don't know the difference.
So heart attack, when we explain to the relatives, we say, he's developed a heart attack.
Yeah.
But when we talk to fellows, it's myocardial infarction or, like that.
Got it. And coming lately, because, you have a wealth of experience of last, let's say, 2 decades, we're hearing a lot of incidents about people in the 30s and 40s today getting affected with incidents like heart attacks and cardiac arrests. What has changed in the last 2 years that, we are seeing that increase?
So what you are pointing at is basically, I think you're talking about heart attack in younger age group. I think the incidence in the older age group more or less has remained the same. We have, as we were discussing before this, we have a lot of aging population because a lot of good facilities are available, and we have a big group of aging population now. Like in the West, our longevity is also increasing. The point is, we have a lot of heart attacks in the younger age group. Like for example, I'll tell you, if I don't see a couple of patients in a week less than 50 years old or anywhere between 35 to 50 coming with a heart attack, I feel I'm missing something. It's become so common. I mean, are we at a point to tell that young age group is also a risk factor for heart attack? Like you say, smoking, diabetes, obesity, stress, family history. These are the 5 risk factors we got.
Yeah.
But do we now incorporate being young also is a risk for heart attack? Well, that is my thought process. Why it is happening? It's happening mostly because there are few things which are coming in my mind right now. One is the stress which is going on right now is a phenomenal. Everybody wants to get into jump the fence very fast. So stress is one thing. I think the pollution is other thing. I'm not going to the common causes of smoking and alcohol and all those things.
Diabetes and
that is everybody knows it. So stress, pollution, I think the food we are eating, all those things, and this will all lead to lack of exercise and obesity and so on and so forth. So stress and pollution are 2 important things. Which are very important, and with this lifestyle of people working in the night, non-physiological, what you call as people go to work at 6 o'clock in the evening and they come back home at 5 and they sleep the whole day. Whatever said and done, you might be having a rhythm in your life, but it's not physiological. We are supposed to stay awake when the sun is there, and so when you start doing that, you're wrong time, and plus eating fast food and all those things, we are well aware about all those things. So
got it.
So these are there, and of course cannot overstress more on smoking, which very unfortunately Now the women have taken up smoking in a big way. Not even just big cities like this, smaller cities. So the protection what women have got, the estrogen protection which goes on till their menopause, is negated by smoking and all those things.
I see.
So these are some risk factors, or these are something which we should look upon and educate people.
Got it. And doctor, in your line of work, I'm sure you probably meet a lot more people because you're an interventional cardiologist when something has already happened and you are called upon often in times of emergency, last minute response times, etc. What are some subtle signs and symptoms that one should not ignore when it comes to matters of the heart?
So the very subtle sign is a chest pain.
Okay.
Most of this chest pain, especially in the youngsters, they always think it is acidity, or I had a dinner last night, outside, stuff like that, alcohol induced, whatever it is. So most of the chest pains are attributed to acidity. Or somebody is working in the gymnasium or something, he'll always say, okay, this is stretch pain, I pumped up a lot of weights and all those things. So chest pain is one thing which, according to me, all the chest pain should be taken seriously. If you want to prevent or if you want to reduce the incidence of sudden cardiac death in our country, every chest pain has to be taken very seriously. Front, back, left arm, right arm, from the neck to the navel, front, back, everything. If there's a pain occurring, especially if you notice it's coming after doing some activity. Like for example, if you're climbing 2 flights of stairs like this, and you are fine, but suddenly one day you find I'm feeling something after this thing, after climbing these 2 stairs. So new onset of symptoms. So these should ring an alarm. And a humble ECG, which is available in every nook and corner. So take it, at least you will diagnose whether you got heart attack or no. There might be other causes of chest pain, but the imminent threat to your life, like a heart attack, can be diagnosed with a simple ECG. So I always tell, even in my general practitioners meeting and all those things, every chest pain has to be taken seriously. If you don't take it seriously, so these chest pains come on activity, on exertion. So these are certain subtle signs. Other things are breathlessness. You suddenly start feeling breathless for the same amount of work you're doing. We have a very audience in Bombay where they have a fixed route to go to their office. I climb one, the other from here to here in Ville Parle. I get down at Churchgate, one, the other. Many years he's doing that. And he's happy. Now he'll come and tell you, when I start doing that, I'm getting this pain. I'm noticing this. So there is something wrong with me, doc. So anything like that. So these 2 things, chest pain and breathlessness, are most common. The chest pain is, again, I don't want to go into details. They radiate. Sometimes they go to the jaw, both the arms. It is associated with sweating. Or, for example, a diabetic person. A diabetic patient will not have this kind of classical symptoms. That's why they develop silent heart attack. So they will have something like breathless, fatigue, weakness, or sudden collapse. So that is typical of diabetic patients. So all these things in diabetic patient, we will call them as angina equivalent. They are not typical angina, but angina equivalent. So these are the subtle signs which we have to take. I'm not telling that every chest pain you should run around, but if somebody has got 1 or 2 risk factors, somebody has got a family history of heart disease. For example, father had a heart attack at 50 years of age, then we know he's standing on a big risk. Even if he's not a smoker, even if he's not anything, we know all those things. So these are certain subtle signs which we have to take it seriously. Unless it is proved, it's normal.
No, those are very helpful tips. The fact that, I think breathlessness and, chest pain, while I think I love the fact that you specified, especially when you're exerting or walking or putting strain, and if there is a sign, I think it's definitely something that people should look for. You also use a term called angina. Could you explain what that is for us?
So angina is a Latin word which is called chest pain.
Okay.
A pain, actually a pain, chest pain, which was described by, I can't remember the person's name. So he described it as, he kept your heart is supposed to be the size of your fist. So
that's it? Only
this much? This is the size. This much. That's the size. So he kept
2.5 kgs, right? like
less than that. No, it's
Okay.
not 2.5 kgs.
Okay,
It's not
much
2.5
lesser.
kgs. Much
Okay.
less, much less,
Okay.
much. So he kept it like this, and he said, that's the pain I get when I walk on a winter when it's snowing, and I had my dinner, and I was walking uphill, and the breeze was there, and he described this. He kept his hand. He said it was a clenching, and it was a pressure, severe pressure. That's where the word angina came from. So
Got it.
that is more of medical terminology what we use.
Got it. Let's talk a little bit about, when somebody comes to you with that kind of a pain, what are the steps that you take as a doctor? What are the decisions that you have to make? Because these
Right.
are decisions which, need to be taken in a split second's time.
Right.
So let's say somebody has come to you with like this kind of a pain. You've noticed that ECG is not normal. In your line of work, what are the established protocols that, clinicians undertake?
Right. So, in a very tertiary care center like hospitals I work in the ER, when patient comes with this kind of things, the ECG comes to us on our mobile, or we have our fellows over there attending the emergency ward. If it's a heart attack, suddenly there's a protocol set in place. The blood thinners are given. So once the blood thinner, and there are some blood thinner injections are also given. Once it's done, we take this patient directly, if it's a heart attack, I'm talking about, we take directly these patients to the cath lab, and we do what is called as primary angioplasty. Primary angioplasty is do the angiography, and that artery is blocked over there. So we put a wire open with the balloon. If there's a clot, we suck out the clot and put a stent. So that is the gold standard of treatment for heart attack in whatever age group you talk about. But this comes in a situation in a very advanced tertiary care system. But let's say the same patient goes to somewhere up far off from here,
Upcountry, Maharashtra.
upcountry, whatever it is, and they don't have the facility. Well, the cath lab is 6 hours away, 3 hours away. You cannot leave him like that.
Correct.
Then what they do is they give him some injections which dissolve the clots.
Okay.
So this was the standard treatment before angioplasty came.
Okay.
So we have various injections which can be given, and now there are very powerful injections are also available. So most of these injections, if it's given in the right time, what we call as golden hour, when they come within half an hour, 1 hour of the chest pain, and when we administer these injections to them, it acts very well.
Okay.
It acts very good, and it gives you time to transport him to a cath lab facility area.
Got it.
So you call them, you say, within 3 hours this patient comes, and you then give this injection to him. If he's very, very unstable, then you have to take a chance, give the injection, and with the cardiac ambulance you have to shift. But if you have time, with the injection he responds, you should transfer him once everything is set and the cath lab is free over there. So you transport him and then do an angiography done. If the clot is completely dissolved with the injection, lucky for him. If there's a residual block which is there, then we go ahead and put a stent over there.
Got it.
So the other group is, let's say, unstable angina, where they don't have a heart attack, but we know there's an impending heart attack. One step before a heart attack, it's called as unstable angina.
Okay.
In unstable angina, we, if it's very severe, of course, we take him to the cath lab. If it's not, we give him blood thinners, injections, give him medications to relieve the chest pain, and maybe we can plan in a day or two and then take him for angiography. Meanwhile, other tests like the cardiac biomarker test, 2D echo, ECG, chest X-ray, all those things will be done. And there we have some more time. But in heart attack situation, we don't have time.
Got it. And you also spoke about two terms. It will be good for our viewers to understand them like laymen, angiography and angioplasty.
Right.
What is the procedure of angiography and how is it like, and what is angioplasty?
Right. So basically, angiography is diagnosis. To know is called as angiography. To treat, it's called as angioplasty.
Right.
So angiography is a catheter which is put in through the right radial artery. Traditionally, it was done by the groin, and because the groin arteries are bigger arteries, more easily accessible. Radial, these are like 6-7 millimeters artery. These are 2.5 millimeters artery. So you need a learning curve for that, and to to puncture the radial artery. And there are several technical this thing. So from these arteries you go to the heart. There are catheters which go through the X-ray scan. You go into the heart, and the catheter goes there, and then it goes into those arteries. So we cannulate all the 3 arteries, and we do the injection, and with the video recording it's recorded, and then it keeps on running in a loop. And so you can magnify, there are various things, software available
and
to
these
us.
are different colors or dyes?
No,
right?
just a black.
Just
a black.
Okay.
The dye with the X-ray, it comes as a black injection.
Got it.
So we can know where is the block, how much percentage of the block, what kind of block. Apart from that, in angiography, we can always find out various other things. Like for example, the size of the artery, the percentage of block, thrombus, whether it's there or what, fresh clot. Calcium is very important because now we see a lot of calcified arteries. So all these things will give us a understanding with what equipment I'm supposed to go in now.
Understood.
If it's calcification, 1, 2, 3, 4. If it's clot, I have to have a catheter to suck out the clot. Or it's straight for balloon angioplasty. Okay, these are my balloons. So it's a big inventory which is there, and it's a very well oiled machine over there with the cath lab technician, the nurse. They're all dedicated over there. So it goes on without any issues. Once we do that, that's called as angioplasty.
Got it.
Angioplasty is earlier when the stents were not there. It was with the balloon, as I told you what I saw in 1991.
Yeah.
But now the stents are our savior,
Yeah.
and we put stents, and stents have done very, very well. If the angiography is showing more than 2 blocks or 3 blocks, or if it's very complex, then we send the patient for bypass surgery. That is done by cardiothoracic surgeons. So that is like a planned procedure which will be done, and that's a whole different ball game.
Yeah. And typically, if somebody is going in for a bypass, there has got to be some time, right? Like
Yes.
or do they or there could be cases where they immediately go for
If
bypass.
the patient is very unstable, and if the disease is, for example, if somebody has got a left main block and right artery block, and he's struggling in pain, his BP is barely recordable. So probably this kind of patients, we send them for emergency bypass. Otherwise, bypass is always planned, because patient is on blood thinner. He was planned for angioplasty. He's on a lot of blood thinners. And for a surgeon to open a chest with all these blood thinners, it's going to be a huge task. They bleed like tap. So then, unless it's very emergency, they will always hold the blood thinners for 4 or 5 days. Then take him for surgery, which is going to be a clean surgery, not much of blood loss and all those things.
Got it.
So bypass is always planned.
Got it.
But it depends again on criticality of the blocks and all those things.
Yeah. No, thank you for simplifying all of this. Let's come to the part which are within our control. And I think you spoke about that, eating the right, diet, and sort of being careful about it. A lot of our audience is actually in the 50s and 60s, right? And typically some of them have some lifestyle conditions, or some are on the verge of it. To them, what would be like your 2-3 words of advice that they can action on a day-to-day basis that can prevent them from having, any cardiac-related events? What would be your 2-3 golden nuggets of advice?
First and foremost is eat less.
Okay.
Eat less, and we don't need to eat so much.
Okay.
We can. I tell my patients one thing. Whatever you are eating right now, just reduce it to half. Eat slowly. Chew your food. I would recommend at least 14 to 16 times you chew your food before it goes into your stomach. That will sort of signal the brain that food is coming into the stomach, and the brain starts releasing the required hormones and so on and so forth, digestive enzymes and all those things. So if we eat very fast, the brain doesn't get the signal, and the whole thing becomes a disarray. The insulin release patterns and all that go away. So eat slowly, eat less. Before you think you will need another serve, stop it. So this is the hunger is here, not here.
Yeah.
So you train your brain to, I'm going to eat 1.5 full cars today. That's it. End of the story.
Be more aware of.
Be more aware.
Yeah.
And don't keep on biting things in between. Have a fixed plan. For me, the best meal is the breakfast, which wherever I'm working or not working, breakfast is the biggest meal for me. Whatever time I get, I try and eat the best in the breakfast. And lunch is going to be a working lunch most of the time, maybe a grilled sandwich or something like that. And dinner is going to be again a very light dinner, maybe a lot of dal, sabji, maybe a piece of chicken or and curds, and maybe one or two bread, or a Indian chapati, whatever it is. So this is where we try and eat at least more of protein intake, less of carbs, less of fat. But you should consume everything. So your plate, what they say, should be as colorful as possible with everything, and good food, cooked food. So Isaac, I want to bring it to your notice that ours is the only country where we still carry our lunch and all those things. When I was training abroad, there is no food made. People go in the morning, get up in the morning, grab a sandwich or something or a croissant in a Starbucks with a black coffee. That's the breakfast. Lunch is in the hospital canteen or IT sector, those areas. They grab something over there. And evening before they go home, 6 o'clock is the dinner. So that kind of lifestyle we cannot do because we are not used to that, because we were brought up in a joint family and a family this thing and all those things. So home cooked food is the best food for us. So make the most out of it. Deep fried, oily food, all those things to be avoided. We all know what is wrong.
Yeah.
But we still indulge into it.
Yeah.
So I would suggest eat less.
Yeah.
Chew properly, and eat healthy.
So very, very diet focused.
Yes.
You're not. And what about exercise? Is there some, let's say a method to exercising for people who are in their 50s and 60s, or walking or running? Are there any things that you tell your patients who are recovering back?
Yeah.
What should they definitely do?
So there are two group of patients. One is somebody didn't have a heart attack, but he's got risk factors. And we know that this guy needs to be taken care to prevent that first event. It can be catastrophic, you never know. So I think simple walk, begin with a simple walk. I feel like 45 minutes of brisk walking with good shoes and in an area and no earphones and no mobiles.
Why is that?
No, just concentrate on your breathing and walk. Just
Okay.
concentrate. I see people in the gymnasium conducting a full meeting on a treadmill. They have a full meeting. They have 4 people. Okay, what do you think? What do you think? Why you come here then? And you're disturbing your neighbors.
Yeah.
So that's not allowed. You do one thing at one time. So simple walk, brisk walk, be brisk, and keep on improvisation on that.
Yeah.
See, when you want to become a singer, you cannot become a singer overnight. You have to practice. So it's like that. You have to keep on practice. And once you achieve, for example, let's say somebody is able to achieve to walk a kilometer in 8 minutes, 9 minutes. It's very good. Then he can go to the next level of doing stretching exercise, doing weights. So build the cardio and build the muscle. Muscle training is also very, very important. Finally, the muscle has to support your skeletal system. If you're just bones, the muscle has to support. Otherwise, you'll start stooping down. So your back muscles, your legs, your thighs, all those things you have to be exercise. So it's ideally a good combination would be do 20 minutes of cardio and another 20 minutes of two pairs of muscles, and then your good food and all those things. So it doesn't take that much time.
Yeah.
So but other group of patients are patients who have got heart pumping which is very low, already had a heart attack, and they are very prone for getting breathlessness. So we start them with the cardiac physiotherapy first, and then we send them for walk. So we make them walk 2 rounds, take rest, 2 rounds, take rest. But whatever exercise they are doing, it's going to definitely help them to improve their pumping of the heart. The third group of patients are overweight patients who you have to sort of counsel them. You go to the gymnasium, there are enough people to wash your brain, and they want you to break the gym in one day. No, that's not the right thing, because you get injured. So when the people obese and all that, start them with good diet therapy and just walk. 3 months, just brisk walking. Once you achieve that fitness, then you start doing your weight training and all those things. 5 times in a week, and the other 2 days you can go for a walk or something like that. And as far as possible, see, I said one more thing I forgot. Once you exercise 45 minutes every day, that does not mean the whole day you go and sit in front of the laptop and you don't walk and you're getting everything on your table. No. Don't take the elevators. walk in the office, you still do a lot of work over there, then only you will get the cardiac benefits. It's been clearly shown that people who spend 1 hour in gymnasium and don't work for whole day are at higher risk. So you are supposed to do that, dedicated 45 minutes of exercise, plus be very active in your work. So a combination of this and diet we spoke, and all these things will take a long way.
Yeah. Let's talk about today's lifestyle, right? People are eating out a lot, and I know you are a big proponent of not eating out at all, or at least minimizing that. But sometimes social engagements happen, etc., etc. So for anybody who in the 30s or 40s watching this, because I think these concerns are more of people who are actively working, they have work meetings, they have social gatherings, etc. What are your 1 or 2 tips for people when they go out? How can they still have a good social time and yet ensure that they are not overdoing or doing wrong things on their plate?
So the thing is, when you have this kind of situations, you have to eat something. You cannot stay hungry. So I would feel first and foremost is eat something that is hot, well cooked. For example, if you are having with a drink or something, which you're having something like a tandoori chicken or a baked fish, eat those things instead of eating all the other stuff which are deep fried oily food and all those things. And maybe for a meal, you can have something like a dal rice or something like that. But I would not eat anything outside which is very oily. You can make it out, it's very oily, and especially the buffets and all those things in a hotel. It's I'm not against it, but if you can try and avoid it, if you can be conscious while you should know what you're eating. You should know what's going in your tummy. So if you start developing that, even by mistake also you will not touch food that is bad. So that's how it is. So eat that is well cooked, less oily, and I keep on saying this: eat less.
Yeah, that's actually
because we human beings are the one animal where after eating they want to eat. We are the only people who eat, and if you see a dessert, you still want to eat the dessert. Animals, they fill their stomach, they don't eat for 5 days, especially the carnivores. So, but we have to develop all those things, and we eat a lot, which is not required for us.
Got it. This is genuinely like fresh and simple advice to follow, like just being aware of.
Absolutely.
You were also telling us, and came up in our discussion the other day, salads in restaurants. You are not a big fan of them. Like, why exactly is that?
So, there are several concerns. I don't know whether this thing, because salad is one thing which is completely raw, which is uncooked. So, I don't know who has cut it. I don't know whether the person has washed his hands. I don't know anything this. It's completely raw food. So, I trust the salad which is made in my home, and because I know the ingredients are bought by me, and I know how clean the kitchen is, and we make sure the helper is also trained well enough to give all this, to take the precautions. In case you want to really eat salad outside or with our kind of dinner, the North Indian stuff and all that, we need some salad, which gives a good taste. I think the best thing is you take the salad, like for example, if there's a bowl of tomatoes, onion and carrot and cucumber, and the best thing is try to put soda over there. Try and put soda in that, and that take it out, put a lot of lime into it, and then start eating. So at least you take away whatever this thing is there, you sterilize it with
foreign substances there.
Foreign substances there, and we don't know whether this was cut in the morning, cut in the evening.
Let's talk a little bit about those who are prone to heart diseases from a gender perspective. Like in your experience, or even within clinical research, are there let's say, are males or females more prone to heart disease? Is at least one gender a little more safer?
So let's talk about first male and female. So the female gender women have protection up to the age of menopause. This estrogen hormone is there, which has cardioprotective mechanisms. So that's why a few years back, when we were doing a residency in cardiology and medicine, we could never see a 35-year-old or a 40-year-old lady coming with a heart attack. Never. Means whenever that kind of lady used to come and get admitted, lot of doctors used to come and see. How come a lady of 35 years or 40 years old got a heart attack? But that pattern is unfortunately changing now. Because the work patterns have changed, the women are stressed out, they are into different jobs. Worst part is the women taking smoking in a big way. So that sort of negates the good effects of estrogen. So men are very prone, women are not that prone unless they do all these things. And this is male and female. So if you are born as a male, you are more prone. That one risk factor is already with you.
Got it.
You are a male. So one risk factor, even if you don't have other risk factors, the one risk factor is you are a male. So we all have one risk factor. So we cannot call ourselves as zero risk factor. First part. Second part is if your parents have got heart issues, it's almost very highly likely that it percolates to you. You are born to a bad genes. It's not your mistake.
Yeah.
Well, that is there. It's not their mistake also. But if you are born to parents, if a single parent, for example, if a father has heart problems or mother, so you are bound to get it at some point in time. But if both have heart problems and there are a lot of family members having heart problems, then you get heart attacks at 30, 35.
Got it.
And all those things. So gender is a very, gender and genetics,
Genes,
both are very important.
So I would just want to understand the genes point a little better. Of course, let's say if my father were a heart patient, but I still can control my lifestyle and,
Certainly.
what all I'm doing. So do I still have enough controllable factors in my living to actually try and prevent it?
Very, very great question. This is what I keep telling. You already have a risk factor being born as a male, then you have family history. On top of it, if you start smoking, if you don't exercise and all those things, you're adding up your risk factors. So you can postpone the events by doing good lifestyle, good diet, and good sleep. Also is a very important, and all the other things which we have spoken about. So definitely you can postpone these events as much as possible.
I think you spoke about diet, obviously, in our generation being very different from, let's say that in the past. Stress and sleep are also two factors which have changed drastically.
Yes.
When I look at how my father and my, let's say, elder relatives in the family would sleep very peacefully for 7 plus 8 plus 9 hours.
Absolutely.
But I don't see any of my friends today actually getting like, let's say 6 plus hours of sleep. Is that a risk factor for coronary?
So insomnia or lack of sleep is going to be the next. I don't think going to be, but is already is a big risk factor for cardiac disease, for cancers, for everything, for late onset mental disturbances. So and cancers are also very. So insomnia is one very, very big risk factor. So 7 hours of sleep is what is recommended up to the age of 50, 60 or more than that. As long as you're getting 7 hours all your life, you're a lucky person. So with our lifestyles, with the cell phones, with the blue light going in our eyes all the time, and we lie down on the bed and we look at our mobiles, we look at our messages and all these things. So this will naturally get you less sleep. So sleep is a very, very important thing. And even if you are not getting good sleep, I would advise start taking some pills, go to sleep, get into a cycle. Maybe you can get away from the pills later. There are nowadays medications where you can take it whenever you want and then you can leave it. So but at least get into a cycle. And so for all these things you need to have early dinner, 1.5 hour gap, avoid caffeinated drinks, smoking or excessive alcohol in the night. Stop seeing your mobiles after 9 o'clock. So then take a shower, whatever it is. So that will take you in the mood of going to a good sleep. So 6-7 hours of good sleep is what is must. Stress, as I told you, we don't have any equipment to measure stress. There is no job which is stress free. So we have to live with it. Well, there are definitely things to beat the stress. One is exercise. Exercise beats stress. Second is what is called as transcendental meditation. It's very easily said than done. It's very, very difficult. So you shut off with all your gadgets and all these things. Try. I've seen people taking 6 months to attain that 15 minutes of peace of doing a meditation. It's very difficult. So this can all reduce your stress level, deep breathing exercises, pranayams and all those things, which is good.
Got it. My last part of this discussion, I want to focus on actually a condition you mentioned as you just came in, which is, what happens to your brain when your heart is suffering, and also vice versa. Yeah. So is brain health connected to heart health at all, or are these two, separate pillars of our, existence?
So when you get a heart attack and when the patient is, what is called as cardiac arrest occurs, if you don't revive him within 3 to 5 minutes by massaging and keeping it going on, then the brain will not receive blood, and there is something called as hypoxic injury to the brain. The patient may become alive, but the brain becomes dysfunctional. So he'll be in a comatose or a vegetative state for long, and we don't know how much part of the brain gets reversed. So heart and brain and other organs are all connected. They're all connected. So this is in that situation. Now, how to keep your brain healthy through your heart is the same thing. Good diet, exercise. See, blood vessels are there everywhere. How does one get problems in the brain? Because there are blood vessels supplying blood to the brain. They get narrowed.
Yep.
There's a fat deposition over there. Or they get clots coming from heart. And then they clog that particular area, and then we call it a stroke. So when somebody gets a paralysis, so paralysis is our word, and stroke and lakwa, what we call it as. So that is a layman's word. So there even blood vessels are there. So the point is to keep all your blood vessels as healthy as possible. So that comes with all the good things what we have discussed. And even now they are having a hypothesis that the old age dementias, Alzheimer's and all those things can also be sort of postponed or prevented by having good circulation to the brain by doing all these good things. So it all boils down to that, how fit and healthy you are. And if you have risk factors, please correct it. If you have blood pressure, treat it. Get yourself treated. If you have diabetes, control it, treat it. Take medicines, make sure you visit your doctors, and keep all the levels, parameters, all the numbers well within the range. Don't get burdened of taking the tablets. Why I should take insulin shot or not? You have to. There's no other way. And if you leave it, you're going to end up in severe trouble from head to toe.
A couple of more questions around the eating part of things, the digestion part of things, because I remember once when we were chatting, you said that, the first sign that something is wrong with your body is probably your gut. Right? So could you elaborate on that a little bit?
So this is not mentioned in any of the textbooks or anything like that, but I feel your gut and the motions you pass is what you eat, how healthy you are. Somebody's passing motion like pellets, like a goat or something, then you know that you're eating something wrong, or your problem with the digestive system. Something which is a normal motion, then you know that you had a right amount of fibers, right amount of carbohydrates, right amount of roughage what you require, all those things. So you are as healthy as your gut. So what happens when you get infection? You get loose motions. With the digestive system of the formation of the stool and all those things go for a toss. So that should not be occurring without having an infection. That means you're eating something wrong. So you have to balance what you're eating so that your gut is healthy. So because you want to eat all your life. So you have to eat food which is gut friendly, more probiotics in that manner. You need to have a portion of probiotic every day. So you build up keep your gut healthy as much as possible.
Right. Thank you for so many of these enriching insights across different aspects of the human body. One point that I want to end this podcast on is a note of hope. So let's say anybody who is watching this, and actually there are two parts to this question. One is, has there been a case history where, you actually felt that this was out of, your bounds, but something that the patient did, or, the medical intervention that was made, which made a miraculous recovery? If you can give us an example of that. That will be great. And then I'll come to the second part.
Oh my God, those are several examples. We had a patient coming to casualty. This was maybe a couple of months back, and as he was talking over there in the casualty, and he collapsed. So then they had to shock him, and they have to revive, and with the massage going on, and we took him to the cath lab. And the massage going on, still the massage going on. We did the angiography and opened his artery, and with the ventilator, with the massage, everything. And he did a phenomenal recovery. So these are really, really gratifying. I mean, these are, then you know that the one life you save, that kick I cannot explain you.
Yeah.
Second was one I remember very, my senior colleague who lives in Bandra East. They were playing lawn tennis. Then he saw, while he was serving, he saw the opposite guy just started swaying, and he just fell down. So he went, he started massaging, and fortunately that society had a AED. You see in the airports and all that AED, automatic external defibrillators, AED. Even in our various other areas in Bandra, it's there.
You see it written.
AEDs, AED, and the sign is like a shock sign.
Correct.
A shock sign.
Yeah.
So somebody went, bought the AED, massage was going on, and they put the pads. The AED machines are talking machines. So once you put the pad, they analyze themselves. Please be away. Shock is being given. So they shocked. The AED saved his life. He was shifted to our hospital. We did an angioplasty. The person walked home.
And this person was a doctor himself?
No, the guy who saved him was a doctor, my senior colleague.
Yes,
but that person was a banker. He was not.
Understood.
So these are, one I showed you in hospital arrest.
Yeah.
One I given an example of out of the hospital arrest.
Yeah.
So these are very, very gratifying. But there is always, you feel sometimes you have done such an extensive job, but then he collapses, and then you feel like whether I should have done this or not. Plus in India, everything is paid by their own pocket, and there's huge bills nowadays. So you always feel, so it's pleasure when you do this kind of things, but most of the time you feel sad that wish you could do it more, wish our system was much lenient in getting all these gadgets free of cost. I think we'll wait for that, and whatever good work we are doing, let's keep doing all this good work.
And my follow-up to that is, with so many technological inventions or innovations rather that are coming into cardiac care, where do you think that cardiac care will it almost become like 0% incident free, or do you think that medical will advance to that stage?
No, I don't think so, because these things, there's a lot of evolution of developing this blockage to treat the blockages. There's a lot of evolution. Now, I was told, I was reading an article where a Japanese, they have, how they give injections when you get a heart attack to dissolve the clot. They have invented something where you can take an oral pill, and it dissolves the clot. Now you got injections to dissolve the clot, not even that, to control your cholesterols. For example, your bad cholesterol, which is LDL cholesterol, which somebody has got, which is not responding to medication. Now we have injections which can be given monthly, or which can be given twice a year, like a vaccine. And those keep your LDL levels. They're expensive, but they're available to us. 3 years back, 4 years back, we didn't have. So somebody, for example, is coming with repeated angioplasties. He does an angioplasty, goes back, 1 year comes back, again one more blockage, same stent blockage. So repeated angioplasties. These drugs, they work. So evolution is evolution and invention is going on like anything. But to say whether this will be zero incidents and no more heart attacks in the world is a tall order.
Got it.
It's a tall order. I don't think so. I hope we reach at that level.
Got it. I do have one last question.
Sure.
Because you said cholesterol, and I know this is again something that I learned from you. Please explain to our viewers why LDL cholesterol is bad and why HDL cholesterol is called the good cholesterol.
Good cholesterol. So what happens is LDL cholesterol is the one which builds the plaque in your heart arteries. So these are the inner surface of the heart arteries, very clean. Blood is going through this, and the vessel is like this. So for various reasons, with risk factors of smoking and all those things, there is a sort of what is called as fatty streak. The deposition of fat occurs. The LDL molecules, they keep on building fat over there, and it keeps on growing. What is called as lipid plaque burden, we call it.
Okay.
And when this lipid plaque keeps filling over there, it is covered with very thin layer, and with various external factors like smoking, diabetes, and all those things, that plaque can rupture, and then you get a heart attack. So HDL cholesterol will sort of prevent these things, but unfortunately, that is the old misnomer of talking about good cholesterol. So we don't have any trials showing that if somebody, for example, has got a HDL cholesterol of 80, HDL, good cholesterol, will he not get a heart attack? The answer is unfortunately no. He still get a heart attack.
Got it.
So the good cholesterol misnomer is not there. But a good cholesterol being low is still a concern. Is still a concern.
Understood.
So our whole focus right now is on the bad cholesterol.
Right.
All the medications which were tested for raising your good cholesterol, unfortunately have failed. There were many medications which came in the market, but they all have failed. So now the whole concentration is how to beat this bad cholesterol down and down. So we have got enough medications right now, and that's where we concentrate. The lower the LDL, and the better.
So it's fair to say that HDL cholesterol does not convert into plaques.
It cannot convert into plaque, but LDL is the plays the mischief.
Fair enough. Thank you so much, Dr. Rao. This was such an insightful conversation. There will be a lot of lessons for anybody who is watching this. We really enjoyed having you on the show. I want to thank you.
Pleasure is mine, and I thank Ivory and Isaac, everybody on the team, having me over here. Thank you very much. I enjoyed this.
Thank you so much.
Thank you.